Welcome to AETCM, the emergency medicine channel. Today we are discussing about high anion gap metabolic acidosis. You know that there are a lot of differential diagnoses for metabolic acidosis in emergency room. Whenever patient is having tachypnea in emergency room, one of the major cause for that tachypnea is, other than respiratory cause I am telling, is metabolic acidosis. It may be sepsis, it may be some alcoholism, maybe elevated urea creatinine. So many differential diagnoses are there. If you see the causes for metabolic acidosis in emergency room, it can be due to increased production of acids, that is ketoacidosis, diabetic, alcoholic, or prolonged fasting or pregnancy can all produce ketoacidosis. Then lactic acidosis, it is mainly due to sepsis or aspirin toxicity and some other causes. Loss of bicarbonate that can occur from GI tract due to prolonged and severe diarrhea. It can occur through kidneys. Renal tubular acidosis, especially proximal type, in which proximal bicarbonate reabsorption is defective. Failure of hydrogen ion excretion by kidneys, that mainly occurs in renal failure, distal renal tubular acidosis. Now, other conditions like ingestions of acids like salicylate, aspirin toxicity, methanol, ethylene glycol toxicity, toluene toxicity. So these are the common cause for metabolic acidosis in emergency room. Metabolic acidosis, again, it is divided into normal anion gap acidosis and high anion gap acidosis. Today we are discussing about high anion gap acidosis or HAGMA. Anion gap is defined as difference between measured cations, that is done in our lab, and measured anions. Cations are sodium, that's a major cation, potassium, calcium and magnesium. So we measure all these things, but sodium and potassium is the major cations. Unmeasured cations are serum proteins and pathological proteins like paraproteins in multiple myeloma. Anions are common measured anions are chloride and bicarbonate. Phosphate is also measured. And common unmeasured anions include sulfates and large number of serum proteins. There are four principal or major causes for high anion gap metabolic acidosis. One is ketoacidosis. It can be diabetic ketoacidosis, prolonged fasting ketoacidosis, or pregnancy related ketoacidosis. Lactic acidosis, mainly seen in sepsis and dehydration. It can also occur in aspirin toxicity and different other conditions. Acute and chronic renal failure and ingested toxins. These are the causes for high anion gap metabolic acidosis. In that, major cause for metabolic acidosis in emergency room is lactic acidosis and ketoacidosis. Lactic acidosis may be septic shock or sepsis induced lactic acidosis and diabetic ketoacidosis. In toxicology, it is alcohol or toxic alcohol induced ketoacidosis. Causes for normal anion gap acidosis are inorganic acid addition like therapeutic infusion or poisoning with sodium chloride or HCl. Gastrointestinal base loss, that is diarrhea, loss of bicarbonate. Renal tubular acidosis, whether it is proximal or distal. So all will produce normal anion gap acidosis. Anion gap is calculated by measured cations minus measured anions. That is, the difference between measured cation and measured anion difference is anion gap. Since sodium is the major measured cation and chloride and bicarbonate are the major measured anions, we can calculate anion gap like this: sodium minus chloride plus bicarbonate. Normal anion gap is somewhere around 12 plus or minus 2. It can be 10 or 14, but 14 is more than 14, we consider it is abnormal, high anion gap acidosis. Some physicians also include potassium, because potassium is also come in that formula in some textbooks, but it is negligible, so we may not consider potassium most of the time. So if you are considering potassium, then it is sodium plus potassium minus chloride plus bicarbonate. That is the best formula, but many doctors may not add potassium because it's a very negligible, like 3.5 or 2.5 like that. So anyway, we can either calculate as an original formula, that is sodium plus potassium minus chloride plus bicarbonate, or for practical purposes sodium minus chloride plus bicarbonate. Normal is 12 plus or minus 2. Anion gap is a difference in the measured cations, that is cation means positively charged ion, and the measured anions, that is negatively charged ions, in patient's serum. So it can be calculated by sodium minus chloride plus bicarbonate. Normal is 12 plus or minus 2. The normal anion gap depends on serum phosphate and serum albumin also. That is very, very important when you are practicing in critical care departments. So when we have to consider albumin and phosphate also. The normal anion gap can also be calculated by 0.2 into albumin gram per deciliter plus 1.5 into phosphate millimoles per liter. So if you are thinking that albumin is low, phosphate is low, you can use this formula also. But a routine emergency physician always use sodium minus chloride plus bicarbonate. But in a critical care, when the patient is having low for albumin or low phosphate, we can use the other formula also. Whatever it is, an elevated anion gap more than 14 strongly suggests the presence of a metabolic acidosis. Now this picture, if you see, we can know that measured cations sodium potassium, measured anions bicarbonate chloride, but there is a gap between the cations and anions, that is anion gap, that is unmeasured anions. We are routinely not measuring that. This protein, phosphate, citrate, sulfate, all these things. So on the right side, you can see elevated anion gap. The unmeasured anions are more. That produce anion gap. That is the difference between this measured cations and measured anions is anion gap. So anion gap can be calculated by sodium plus potassium minus chloride plus bicarbonate. So we will see the causes now for HAGMA now. There are two important causes: increased endogenous acids, increased exogenous acids. Endogenous acids are diabetic ketosis, accumulation of ketone bodies, starvation ketoacidosis, lactic acidosis, that mainly due to tissue hypoxia produced by shock, sepsis, dehydration, hypotension, cardiac failure, all these things, and liver disease. Renal failure can produce accumulation of organic acids like sulfates, phosphates, and urates, can also produce HAGMA. Increased exogenous acids are mainly seen in toxicology, like aspirin poisoning, accumulation of salicylate, methanol poisoning, accumulation of formate, ethylene glycol poisoning, accumulation of glycolate and oxalate. So either exogenous acid is increased in toxicology, like toxicological cases, or endogenous acids are increased, like DKA, starvation, sepsis, renal failure, all these things. Now we will see the role of albumin and phosphates in calculating anion gap. The normal anion gap depends on the serum phosphate and serum albumin. Corrected anion gap, when there is hypoalbuminemia, is we calculate an anion gap according to the previous formula plus 4 minus serum albumin. That will give the difference in albumin from normal into 2.5. That will give corrected anion gap. So whenever there is hypoalbuminemia, that is a very common condition in sepsis and all. We get albumin is low. So whenever albumin is very low, we have to go for a correction in the anion gap. The normal anion gap can also be calculated by 0.2 into albumin plus 1.5 into phosphate. That also gives anion gap. That occurs mainly when there is phosphate deficiency or hypophosphatemia or hypoalbuminemia. Both are coexisting in same patients with high anion gap acidosis. We have to calculate exactly what is anion gap. Albumin is major unmeasured anion and contributes almost whole of the value of the anion gap. It is a major part of the anion gap. In hypoalbuminemia, every 1 gram per deciliter decrease in albumin will increase the anion gap by 2.5. So it is very important to calculate the anion gap according to the albumin in critical care patients. A normal high anion gap acidosis in a patient with hypoalbuminemia may appear as a normal anion gap acidosis. So it is very important. It can mislead your diagnosis when there is hypoalbuminemia is present. So that should be taken care. So you have to correct the anion gap according to the albumin in hypoalbuminemia. The formula is like this. We have explained in detail about that. Now whenever we have high anion gap acidosis, we have to observe some of the other things also. In addition to being equal to the difference between measured cations and anions other than sodium, potassium, chloride and bicarbonate, the serum anion gap is also equivalent to serum anion gap is equal to unmeasured anions minus unmeasured cations. Thus an increase in the anion gap can be due to it can be produced by fall in unmeasured cations, that is hypocalcemia or hypomagnesemia also. So that also come into picture whenever there are hypocalcemia or hypomagnesemia in a patient who is in critical care. And some patients with accumulation of lactates or keto acids, hyperalbuminemia, all will produce change in the anion gap. So in critical care patients, we have to use other formulas for calculating anion gap. As an example, both hypoalbuminemia, that is decreased unmeasured anions, and hyperkalemia, increased measured cations, it is not basically used in primary formula, can lower the serum anion gap. So use all these things, all the formulas to get an exact anion gap whenever you are in doubt. A patient with both of these disorders could have a baseline serum anion gap of 2 to 6 rather than 10 to 14. In these settings, a serum anion gap of 14 milliequivalents, which is only moderately above the normal range, represents a true elevation in the serum anion gap. That is the importance of all these things. So whenever you are getting a normal anion gap acidosis in a patient who is having hypoalbuminemia, hyperkalemia and all, you may miss high anion gap acidosis. So it should be taken care of. HAGMA can be produced by fall in unmeasured cations, that is hypercalcemia or hypomagnesemia, which are not used in the primary formula. So all these things should be taken care. So whenever you have doubt, use more accurate formulas like what we explained. Otherwise, simple formulas in emergency room will give an average diagnosis, but when you are using this the formula in critical care, you have to use more specific formulas for that condition. Now we'll see the disadvantages of anion gap calculations. Reduced anions, that is hypoalbuminemia, which is a common critical care illness which reduces anion gap and may mask the elevated anion gap that we have already explained. Unmeasured cations such as lithium in depressive patients and hyperglobulinemia like in multiple myeloma can also reduce anion gap. Hypercalcemia and hypermagnesemia also can reduce the anion gap. Calculation of anion gap involves the measurement of electrolytes, therefore it depends on the accuracy of measurement process. So if we are not using a machine which is not calibrated properly, it can also produce abnormality in the anion gap calculation. So we have explained about anion gap acidosis. This is one of the most important cause for acidosis in emergency room. There are a lot of different formulas are used in emergency medicine and critical care patients in anion gap itself. So the knowledge about all the factors which can alter the anion gap is very, very important. Thank you.